good overview that SUs will be there. They are there, and for our Indian population, and we are using it for years and years in our patients, and they are definitely showing efficacy, durability, and along with the newer agents, we can use them judiciously. Over to you, Smith. Any comment?
No, I think it was a very clear-cut message, and probably our faith in SUs is, it's redefined and it's there always.
So thank you, Rajiv.
Thank you so much, Ashish. Thank you for calling me.
Thank you for
Have a
nice
wonderful
deliberation.
conference.
And thanks a lot, Professor Dr. Smith and Dr. Sushit Kelly, sir.
Thank you, Ashish.
Sharing the session very nicely and getting the questions and discussed with the speaker. And moving on to the next topic by none other than our Professor Dr. Noshi Yusuf from Egypt. And he's a very good friend of mine, and he has taken the very important topic that does statin use increases the risk of developing diabetes. Let's discuss it today. So I will request Professor Smith and Prashant to be here because they are dealing with cardiology patients. And to introduce with me are my respected chairpersons, Dr. C.H. Vasant sir and Dr. Rakesh Sai sir. C.H. Vasant sir is Senior Consultant Physician, Apollo Hospitals, Hyderabad. And Dr. Rakesh Sai is a very well-known personality and a very humble and very good friend of mine, Professor and Head Department of Endocrinology, Usmania Medical College and Hospital. Over to you, respected chairpersons.
Yeah, thank you, Ashish, for inviting us to be here. And I would like to go on. I mean, we'll move on with the session where I'll introduce Professor Nosbi Yusuf. He is from the Cairo University in Egypt, and he is currently he's a senior consultant physician in cardiodiabetes at Asyut in Egypt. He is the founder and director of Cardiodiabetes Secrets International Group, and also the president of Egyptian Cardiodiabetes Association in the year 2020. And he's also awarded the fellowship of the American College of Cardiology, and is a member of the American Diabetes Association. So we have with us Professor Yusuf, who's going to discuss about this contentious issue, which comes up very often, that statins increase the risk of causing diabetes, and he's going to clarify this. How much is the risk? How should we go about, because this risk is there, we need to prescribe statins, and how do we choose among the statins? So these are the issues, I think, which are going to be covered by him, and I'm sure this is going to be very interesting talk for all of us. Over to Professor Yusuf.
Over to you, Noshi sir. You can share your screen. Yeah, thank you.
Yeah. Good afternoon, everybody.
Good
First,
afternoon.
I would like to thank Dr. Ashish Dengra for inviting me and his board. I also thank my co-chair, my chairman, for this session. And I would like today to discuss this topic, which is controversial topic. Does statin use increase the risk of diabetes? Let us see what it will do. So first, I have no disclosure to see. This is my agenda about statin and diabetes, meta-analysis of randomized clinical trials, and the proposed mechanism of new onset diabetes induced by statin. So statin and diabetes, now we can call it a group of diseases or disorders which is characterized by vascular affection and manifested by hyperglycemia. Statin are the second revolution in medicine after penicillin, and the statins are the first-line therapy for prevention of primary and secondary cardiovascular disease, which is the leading cause of mortality worldwide and the main cause of mortality in diabetes. A statin has a pleiotropic action include favorable effect on systemic inflammation, endothelial function, oxidative stress, and this is an important mechanism involved in the etiology of cardiometabolic disease. This effect might be predicted to reduce diabetic risk, but instead, accumulative evidence suggests that the use of statin may increase the risk of developing diabetes. So, what already we know about this subject? In some observational studies, statin use has been associated with increased risk of diabetes, and data from randomized statin trials also suggest the incident diabetes is increased. And the new finding in a population at high risk of diabetes, which is the incident diabetes was rigorously detected, statin use remain a diabetic risk factor. Incident diabetes among statin users are accompanied by a decline in the insulin secretion. So we came to the main subject of my topic, that meta-analyses of randomized clinical trials. They showed that some of these meta-analyses showed statin treatment associated with a small increase, approximately between 10 and 12% in the risk of incident diabetes compared to placebo. And this diabetogenic effect of statin may be more important among individuals at higher risk of diabetes. So this study was published in the Lancet, and statin and risk of incident of diabetes at a collaborative meta-analysis of randomized statin trials. And this trial was the collected data 15 years from 1994 to 2009, and it include more than 1,000 patients. And the finding, they identified 13 statin trials with 91,000 participants, in whom almost half and half assigned for statin or no as control group with no statin. And the mean was 4 years duration. Meta-analysis regression showed that risk development of diabetes with statin was highest in the trial with older participants. And treatment of 255 patients with statin for 4 years result in 1 extra case of diabetes. So they conclude that the clinical practice in patients with moderate or high cardiovascular risk or existing cardiovascular disease should not change. The second trial we'll see statin do not increase the risk of developing type 2 diabetes in familial hypercholesterolemia, and it is a safe heart study, and it is published just a few years back. And they collected cohort study, collected about 2,500 familial hypercholesteremic patients with 1,200 unaffected relatives of this group with mean follow-up of 5.9 years. And the results showed the new onset diabetes was 1.7 familial hypercholesteremia compared to 0.2% in non-familial hypercholesteremic patient with significant p-value. But in adjusted Cox regression model for familial hypercholesteremia group and age and the metabolic syndrome, they remain significant predictor of new onset of diabetes. And they concluded that our data do not support the postulated diabetogenic effect associated with high dose statin use in our cohort study for familial hypercholesteremic patient. We come now to another study published in 2016, Statin Use and the Risk of Developing Diabetes, a network meta-analysis. And this study was collected data between August 2010 and June 2014, almost 4.5 years. And the result, they found 29 trials with more than 163,000 participants have been randomized. And the significant increase is likelihood of developing diabetes by 12%. Atorvastatin 80 was associated with the highest risk of diabetes, followed by rosuvastatin. And also they make the order of simvastatin 80, simvastatin, atorvastatin, paravastatin, lovastatin, and pitvastatin. So they concluded that statin as a class increased the risk of diabetes significantly in the pairwise meta-analysis. Next study showed this study was published in British Medical Journal in 2017, and it collected from Diabetes Prevention Program Outcome Study more than 3,200 participants. And the result they showed after 10 years, at 10 years of cumulative incidence of statin, there was statin use was associated with greater diabetic risk irrespective of treatment group. And they concluded that this population is at high risk of diabetes and significantly higher rate of diabetes with statin in all three groups in this study. And the effect of statin to increase diabetic risk appear to extend to population at higher risk of diabetes. Another study was published in 2019, a review of pharmacist intervention on diabetes outcome and observational analysis to explore the diabetes care opportunity for pharmacists. And somebody is opening his mic. Database used include PubMed, Web Science, Science Direct, ProQuest, Scopes, and Avoid Medline. And that it collected data from January 2012 to September 2018, almost 7 years. And the total of 5,800 studies were identified. And from this huge number of studies, they found the unique studies was 380. And the full text of 59 papers were excluded, and finally 25 papers were included in the review process. And they concluded that pharmacist intervention in diabetic patient can be result in a better control of disease and its complication, and can help to improve quality of life in the patient. Another study published in Journal of American Heart Association in 2019, time and dose-dependent association of statin use with risk of clinical prevalence of new-onset diabetes in primary prevention. And the method, it is cohort adult study aged more than 40 years with hypercholesterolemia who would be eligible for statin therapy for primary prevention. And the duration of the study was from 2005 till 2012. And the primary outcome was the occurrence of clinical relevant new onset diabetes. They found that among 2,126,000 adults with hypercholesterolemia are eligible for statin. 29.5% ever used the statin, and 70.5% never used the statin. And the mean follow-up was 3.9 years. And the ever used the statin was significantly associated with diabetes mellitus risk compared with never used the statin. With increased duration of statin use, the risk of diabetes was proportionally increased, and excess risk of diabetes was also associated with higher intensity. And they concluded that in patients receiving statin therapy for primary prevention, there was a time and the dose dependent association of statin use with an increased risk of new onset diabetes. Another study was published also in 2019, association between statin treatment and new onset diabetes mellitus, a proportion-based case control study. About 1 million participants, 6,400 almost participants with new onset diabetes in 2012 till 2013, and 32,000 control without diabetes, and they followed for 3 years. And the result of this study, after adjustment of covariates, there was no significant difference in the risk of new onset diabetes when analyzed according to cumulative use days. The risk of new onset diabetes was increased only in short-term and recent users group. And they concluded that the risk of new onset diabetes was not associated with an increase in the cumulative duration of statin use or non-recent use. Only recent short-term use of statin was associated with increased risk of new onset diabetes. This is also published in 2020. Statin treatment induced development of type 2 diabetes from clinical evidence to mechanistic insight. And clinically, these findings encourage the clinician to consider diabetes monitoring in patients receiving statin therapy in order to ensure early diagnosis and appropriate treatment. And the statin are the golden standard treatment for prevention of primary and secondary cardiovascular disease, which is the leading cause of mortality worldwide and main cause of mortality in diabetes. Observational studies, clinical trials, meta-analyses indicate an increased risk of developing new onset diabetes type 2 after long-term statin treatment. The mechanism involved include impaired calcium signaling in pancreatic B cells, downregulation of GLUT4 in adiposity, and compromise insulin signaling. And they review the multifactorial combination effect of these most likely contributes to the diabetogenic effect of statin. I am sorry for this multiple studies and meta-analyses, but it is in the main of the subject. And now we can come to the proposed mechanisms for new onset diabetes induced by statin. The beneficial effect and the complication and or the inflammation in type 2 diabetes, the atherosclerotic cardiovascular disease is the main mortality cause in type 2 diabetes. Dyslipidemia, increased oxidative stress, enhanced protein glycation, chronic inflammatory state, all of them worsen type 2 diabetes. And this we'll see that statin discovered earlier, as we all know, statin discovered earlier in 70s and commercially was available in mid-80s and have well-characterized benefit in terms of lowering LDL and cardiovascular reduction. 20 years, it is very strange that after 20 years of being commonly prescribed, observational studies showed that increased type 2 diabetes risk upon statin admission in several populations. Considerable variability among these studies. And the justification for the use of statin in prevention, as in Jupiter trial, it showed that a small but significant increase in the diabetes incidence rate in patients who received the statin treatment when compared to placebo over median of 1.9 years. And this is a proposed mechanism of statin-induced new onset diabetes in the adipose tissue, in the muscle, in the liver, in the beta cell of Langerhans. So in pancreatic beta cells, the statin will have to block the L-type calcium channel, which prevent introduction of calcium inside the cell and pump the insulin outside the cell. Another also GLUT2 mRNA messenger are decreased, GLUT expression also decreased, and many affection for the mitochondria. In the adiposity, statins also will have PPAR gamma expression decreased, and the isopresent synthesis also is decreased. This also will affect the GLUT4 translocation, which allow the glucose to come inside the cell. In the muscle cell, statin will have GLUT4 translocation impairment, and this can lead to also to a decrease in the insulin and coming inside the muscle cell, and also it can affect the HM-CoA reductase enzyme, and this also have shown to decrease the insulin consumption. In hepatocytes, statins will affect the increased TSH receptor and ultimate increase in free fatty acids. So now we can come to the hydrophilic and lipophilic statins. Lipophilic statins like atorvastatin, simvastatin, lovastatin, fluva, and pitva are more diabetogenic than hydrophilic ones, parava and rezuva. And the effect of statins are dose dependency and primarily related to the lipophilicity. So in conclusion, clinical studies to in vitro and in vivo experimental studies confirm and reinforce the diabetogenic effect of statin. Although the number of questions remain unanswered, the available evidence support that statin do increase the chance of type 2 diabetes, with some statin being more strongly related than others. Strongly related statins, simvastatin, rezuva, and atorva, and the less one is parava. So it's still favorable risk-benefit ratio of statin therapy is there. The diabetogenic effect of statin is related to the dose, to the lipophilicity, and duration of use. Mr. Chairman, overall the risk of incidence of diabetes with statin therapy is present, but, and a big but, largely outweighed by the actual cardiovascular benefits. Thank you. And I would like to share with you our global Facebook group, Cardio Diabetes Secrets, which is more than 20,000 participants, and it have daily more than 10 to 15 new posts. Also, we will do our first Cardio Diabetes Secrets annual conference on 22-23 this September, and the registration is on the Facebook group Cardio Diabetes Secrets. Thank you very much.
Thank you. Thank you, Dr. Yusuf, for the excellent presentation where you showed a lot of evidence about statins and the risk of diabetes with the use of statins. So although you have concluded saying that the benefits of statins far outweigh the risk that is there for the development of type 2 diabetes, but still we need to be wary of this. We need to be aware of this and probably choose the statin therapy. The choice of statin and the dose of statin probably would be influenced by this fact that you have stated just now. So I would like to have your opinion on that. How would you decide on the statin and the dose if you had to start a statin now? How does this information influence your decision on starting the statin?
First, thank you very much for your elegant question. And I would like to say that first, the statin, if it induce new onset diabetes, so it is simply managed maybe in more than 90% of patients by metformin alone. And I have many patients who have statins for 20, 15, and 10 years, and some of them have developed diabetes, and they only take metformin 1,000 per day, and they are well controlled, and their A1C will become less than 6%. So first, second, I would like to answer your question that when I choose a statin, I have to concentrate on LDL. And by LDL, I will categorize the patient to have high risk or very high risk to choose the dose of the statin to decrease his LDL to 50%. And all of us know that our age is the age of our arteries. So I would like my arteries to be small in age, so I will have more longer life. So I would use a statin for myself, for everyone to have a very good, healthy arteries.
Thank you, sir. One more question I would like to ask you is, do you have any data on this pitavastatin? This is a new statin which is available in India. I'm not sure whether it's available in Egypt. Do you have any data on this pitavastatin? Because some of the data available says that pitavastatin probably has a lower risk of causing new onset diabetes. What is your experience with this?
Pitavastatin also available in Egypt. It is a medium intensity statin, and it also belonged to the lipophilic ones. So the more safe is rosuvastatin and the paravastatin.
Okay, so it is less than rosuvastatin, you mean to say?
Yes.
It has lower risk.
If you wanted to use pitavastatin, you should go for high doses, 4 milligram. So the incidence of new onset diabetes can be more, and its effect on LDL will be less.
Okay.
So, Dr. Noshi, you told that rosuvastatin is better than the other statins, and as they have the less chances of developing diabetes, new onset diabetes.
Yeah, from its hydrophilic characters, hydrophilic characters. Although in the high dose of rosuvastatin, 20 and 40, especially 40, the incidence of the new onset diabetes and more like atorvastatin 80, but in the small dose of 10 milligram rosuvastatin or 20 milligram rosuvastatin in very high risk patient, the incidence will be less compared to the lipophilic ones.
Rakesh sir, there are some questions in the chat box. Can you take?
Yeah. Okay, so there's a question from Dr. Panda. Jayant Panda is here. He is asking whether you would recommend pravastatin than rosuvastatin and atorvastatin. In India, we don't have pravastatin available. So do you have pravastatin available in your country, and would you prefer that to rosuvastatin? And
I think lovastatin is now obsolete. It is not used nowadays.
Pravastatin?
Pravastatin is not available also in Egypt.
Yeah. And
it is the most safe one, pravastatin.
Yeah, you also discussed another question was there from Dr. Panda only, who asked about the differences in the glucose intolerance potential, which you've already discussed. You spoke about the differences in the effect of various statins, and you showed that there is a difference, and the choice should depend on this difference. And the message, I think, is very clear from your presentation that don't worry about the risk of diabetes, worry more about the LDL lowering that you can achieve.
Yeah. So, and I would also emphasize that the treatment of new onset diabetes of statin is 90% or more require only metformin.
Yeah. There's a question from Dr.
Raka.
Raka wants to ask a question.
Dr. Noshin, Dr. Noshin, what is your comment on triple drug combination which we use here in India along with aspirin, clopidogrel, and statin? What is your opinion? Whether it works in that combo or not?
In Egypt here we have no combination like this, but I think it is acting well. No problem, because it is manufactured to have the three together.
Yeah, it improves the compliance, particularly in patients
Indian.
immediately peri-procedure and all that, where they require the dual antiplatelet action along with the statin, so to reduce the number of drugs that is being prescribed. And Dr. Noshi feels that that should be a good combination,
yes,
although he has no personal experience on that. Yeah.
So thanks a lot, Noshi, and very good discussion. And thanks a lot to Rakesh sir for being here with us and blessing the occasion every time he's with us. Thanks a lot, Rakesh sir.
Thank you.
And
thank you very much.
Good deliberation,
for all of you,
Dr. Noshi.
And special thanks for Dr. Dengra.
Thank you, Dr. Noshi Yusuf, and we are very much privileged to be that you are here and you have accepted our invitation. And definitely there are many more topics and conferences there. We will invite you to for deliberation of another topics. Thank you. Thanks a lot.
Thank you very much, and I hope we will see you face to face in the near future.
Yeah, definitely. Thank you.
Yes.
Because we are facing the COVID situation. It will be over very soon with the blessings of God and everyone. Thank you. So moving on to the next topic, it is another